Hey everyone, welcome to Steadfast Care Plan, where we plan for care to live well. I'm Kelly Augsburger, long-term care insurance specialist and your guide. With me today is Dr. Goel, cataract surgeon and comprehensive ophthalmologist with the Regional Eye Associates in Cherry Hill, New Jersey, as well as a clinical spokesperson for the American Academy of Ophthalmology. Dr. Goel, thanks so much for being here.
Thanks for having me.
Today, we are going to be talking about how people can see well as they grow older. So can we jump right in?
Sure. I think that my goal in life is to protect sight and to help patients lead healthy lives. And the Academy's mission is protecting sight and empowering lives. I finished residency back in 2001, and I'm a cataract surgeon and a comprehensive ophthalmologist right in my hometown where my family's lived for 50 years. And I think that ophthalmology and, fellow ophthalmologists, we have that mission to help our community members, help our neighbors lead healthy, productive lives. And especially as we see the population getting older, we see the potential for vision loss or, visual demands, but the potential for vision loss to increase as the decades go on. A lot of our efforts are to help manage our patients and help to treat them and to give them the goals and the steps to help to lead healthier lives.
Thank you, Dr. Goel. How often should this older adult population get eye exams?
So the mantra always is that by the age of 40, you should have an eye exam, comprehensive eye exam with an ophthalmologist. Ophthalmologists are physicians and surgeons. We go to 4 years of college, 4 years of medical school, 40 years of residency, maybe 1 to 3 years of fellowship. But I think that, at the age of 40, you should get an eye exam. Once you get older, if you have risk factors, you should have eye exams more frequently. Certainly when you're at the age of 65, which I think many of your audience are, they should have an eye exam at least once a year. And if there are other additional risk factors every year or two, and sometimes more frequently, depending on what their clinical findings are.
Gotcha. And then what's the difference between an optometrist and an ophthalmologist? Because I think most people probably don't know the difference.
Oh, that's great. So there are the 3 O's. Okay. Ophthalmologists, optometrists, opticians. That's what we talk about, the traditional 3 O's in eye care. We're all part of an eye care team. So as I mentioned, ophthalmologists are physicians and surgeons. We go to 4 years of college, 4 years of medical school. We generally have an MD, medical doctor, or a DO, doctor of osteopathy. So MD DOs. Then we do 4 years of residency, hospital-based residencies. Then typically we may do 1 or 2, maybe 3 years of fellowship. And then we come out, we join a clinical practice or a faculty or private equity, whatever. And then we go through board certification. Optometrists go to 4 years of college, 4 years of optometry school. Mm-hmm. And then they may have 1 or 2 years of a residency. That can be anywhere from like a Walmart or a Kmart or like through a mentorship. Some of the eye institutes in the country have residency programs, but they're not trained to do cataract surgery. They're not trained to do intensive surgery. In only 10 states are they allowed to do laser surgery. So that's a big scope of practice battle we have with optometry currently. And up until the late 90s, they weren't allowed to prescribe drops in the state of New Jersey. So that can be a state-by-state issue. So really, in terms of patient safety, you need to know who the person wearing the white coat is in front of you. Are they an ophthalmologist? Are they optometrist? Are they optician? Opticians are those who fit you for glasses. Generally, optometrists, they do routine care. Optometrists throughout the spectrum, they do general eye exams, contact lens fittings, low vision, etc. But in terms of medicine and surgery of the eye, that's ophthalmologists.
Okay, thanks for clarifying that. I learned something new today.
Yeah, exactly.
Thank you for that. And then what kinds of things can eye exams catch before the person may even know that they have a health issue? What do you tend to see?
I can count a number of patients who I'm doing a routine eye exam on them. I sit back and say, "Oh, how long have you had diabetes?" And they say, "I don't have diabetes." I'm like, "Oh," then I know that's going to be a longer eye exam because I have diagnosed their diabetes.
Oh my goodness.
I remember being a resident looking in a routine eye exam. I did my residency down in Baltimore, and every employee in the hospital got a free routine eye exam through the eye clinic. So all the residents did routine eye exams. And this patient's eye, I can still see it. This patient's optic nerve was swollen. Came in for a routine eye exam. I was like, what is going on? I called my senior resident in. We sent him down to the ER and he was in kidney failure. So he was an African-American gentleman in his 40s. You get other risk factors, but you can have diabetes, high blood pressure. You can diagnose cancer in the eye.
No
you can
kidding.
Diagnose primary cancer in an eye exam, or unfortunately, you can diagnose metastatic cancer, where you have a primary cancer somewhere else in the body and it goes to the eye. Common diseases such as MS, multiple sclerosis, or sarcoidosis, a bunch of diseases will have clinical signs that are in the eye. High cholesterol, high blood pressure. I'll look at a patient. I'll be like, hey, your blood vessels look, very tenuous. They look like they're being pulled or whatever. So you can have patients who have signs of stroke. Your audience is going to know about TIA. Well, patients who come in and say, I've been losing my vision for 15 minutes a day. And then it goes fine. A curtain comes over my vision. I'll look at the patient. I'll say, ma'am, you're having a stroke, or you're at high risk of a stroke. We need to call 911 and send you to the emergency department. Sometimes when I lift a patient's lid and it's really soft, it's really easy for me to lift, I'll sit back. I'll say, do you have sleep apnea? And the patients will jump back. They'll be like, how did you know I have sleep apnea? I say, well, because there's something called floppy eyelid syndrome, where we can literally just move a lid. And when you've looked at thousands of lids, you're like, oh, it looks like something called a floppy eyelid. And that could be a risk factor for sleep apnea. So at that point, we say, look, you could have sleep apnea, but I'm not going to say you do. So we're going to send you over to our MD colleagues, our primary care physicians, et cetera. But, I've diagnosed brain tumors. I've diagnosed aneurysms indirectly. I saw a patient, I don't want to be too specific, but they were going on vacation, a few days later, and I looked in for a routine eye exam, and I look in the eye, and the optic nerve was a little swollen on both sides. I said, something's going on. And I added tests that day. I extended their visit. I sent my clinic back. I said, I got to send you to the ER. She called and said, thank you. Because of you, I was diagnosed, not because of me, but you found my brain process. You could have thyroid eye disease, some patients whose eye are sort of bulging out, proptosis.
Yeah.
So there are all sorts of things that you can find on a routine eye exam. You have to have that clinical suspicion. You do always what's in the best interest of the patient. But, back in the 90s when they were talking about primary care, we would present ourselves as being primary care of the eye. OB-GYNs were primary care, for women, pediatricians, internal medicine, et cetera. We're like, hey, we're the primary care of the eye. Our colleagues outside of ophthalmology, they're seeing patients for, high blood pressure, cholesterol, et cetera. They don't want to manage the eye stuff, and they don't have the equipment to either. So those are just some of the things you can find on routine eye exam. So
that is fascinating. I've heard of some of those things that you talked about, but others not. Really, it just makes me think that the eye is like a window into a really good picture of your health. So if there's
the one thing I'll tell you, the eye is the only place in the human body that I know of in which you can look at a blood vessel without cutting into tissue. We can look at a lens or take a photo. We can look at arterioles, arteries, and veins. The only place you can look at that in the human body without cutting tissue. You can look right at it in the back of the retina. That's actually really nice. That's cool.
That is so fascinating.
The Steadfast Care Planning podcast is sponsored by Amada Senior Care. Amada provides complimentary consultation with a senior care advisor to find the right care, from in-home caregiving to community care, as well as long-term care insurance claim advocacy and unique support partnerships for financial advisors to address family transitions and generational retention. To learn more, visit www.steadfastwithamada.com.
What types of eye diseases or complications do you tend to see in older adults?
The typical ones, cataracts, glaucoma, macular degeneration. Those are the three leading causes of vision loss as you get older. Diabetes, diabetic retinopathy. Those are the main causes of vision loss. I mean, if you think about, there's this old study in the 80s or 90s called the Baltimore Eye Survey. And the Baltimore Eye Survey was done at Johns Hopkins Hospital.
Okay.
They hypothesized, what's the most common cause of vision loss in Baltimore? And the punchline is that a mile or two from Johns Hopkins Hospital, for many years, number one eye hospital in the world, the number one cause of vision loss in Baltimore, Maryland at the time was cataracts. Garden variety cataracts, where patients didn't have access to seeing an ophthalmologist, not even knowing that they had a cataract. So I think that, cataracts, glaucoma is the thing that you lose sleep over as an ophthalmologist because it's a silent disease. People don't know that they have glaucoma. So for example, somebody who has glaucoma typically can be over the age of 60, has a family history, ethnicity, Asian Americans, African Americans, Hispanic Americans, history of high eye pressure, also a history of diabetes, high blood pressure, or if they're on long-term steroid use. You could be on steroids for, whatever condition that your other colleagues want to put you on, and that can cause high pressure in the eye, and that can cause, in this case, a secondary glaucoma. But glaucoma is one of those silent diseases. We talk about cataracts.
And can you describe, Dr. Goel, can you explain to us what the differences are between glaucoma, cataracts, and maybe age-related macular degeneration? What do those look like? Because I don't think most people really understand what they are and what the differences are between them.
Sure. So basically, you can imagine a camera system. Like if you're taking a photo of something, remember those old photo systems? You had to you got the film, you had to mail it out to to a lab and get it processed. Yeah. Well, it's the same thing. Like if you have a camera, you have the lens. Okay. Imagine that lens being clear. And as you get older, the lens will get cloudy. So imagine the natural lens of the eye. So when light comes into your eye, the first thing it hits is the tear film. And then it hits the cornea, which is sort of that dome in front of the eye. Okay. Then it goes through something called the anterior chamber. Somebody has blue eyes or brown eyes. That's called the iris. And the opening is called a pupil, almost like a student. The history of the word pupil came from the teacher and the student was upside down when you look right at somebody. So that's what I'm told anyway. Yeah.
Okay.
So you have the tear film, the cornea, the anterior chamber, then you have the pupil. Right behind there sits the natural lens of the eye. And I typically tell patients that think about a peanut M&M. A peanut M&M has a peanut, the chocolate, and the shell.
Yeah.
Okay. That's the classic peanut M&M. And imagine that being a lens in which the lens has a clear peanut, a clear chocolate, and a clear shell.
Okay.
You can get cloudiness in any of those layers, like lens proteins, it's called. Lens proteins will change so that lens gets cloudy. So it's almost like driving along the highway and it starts to snow and you haven't turned on the windshield wipers, right? So you're gradually getting snow. You can sometimes see through it, a couple of flakes, but as the flakes get more and as it gets thicker, you're going to have more trouble seeing through the lens, okay? So then light travels from the tear film to the cornea, through the anterior chamber, through the pupil, hits the lens. That's where you can get a cataract. After that, it hits something called the jelly of the eye, the vitreous gel. Almost like that thing being like jello. That's a clear substance that helps to sort of process light. And then it hits the retina. The retina is sort of that dome in the back. And that has, 9 layers to it. It's a little more detailed. But that retina layer is sort of a conduit to the brain. That has nerve fiber layers, etc. But that processes information. That's the film, okay? And the film then, it processes, goes to the optic nerve, sends information to the optic nerve. The optic nerve sends it off to the brain, et cetera, for processing. So when it hits the retina, that's where you can have a lot of diseases. You can have macular degeneration. You can have diabetic retinopathy. You can have those blood vessels I mentioned, which were high blood pressure, or you can have those soft signs of something called embolus, somebody's having a stroke from the heart, something called a Hollenhorst plaque. You throw off a plaque from the heart, goes to the eye, hits the retina, stops at the retina, hopefully. And then the optic nerve sends information to the brain, and that's where you can get glaucoma, the optic nerve.
Okay.
The optic nerve, the way to think about an optic nerve, think about you have an ice cream bucket. You have a bucket of ice cream. You take a scoop of ice cream from the center. If that bucket is 10 across, you take a scoop in the center about 2 or 3 across. That's the typical size of the optic nerve. There's no average sort of in a podcast, but like 2 or 3 or 4, you take a scoop of ice cream, the diameter of the scoop is 3 or 4, the radius, the bucket's 10, distance across. And there are disease processes that can cause damage to the optic nerve over life, over time. Glaucoma is one word, but it has many sub-diagnoses under that. This glaucoma, that glaucoma, open angle, closed angle, long-term, short-term, fast, slow, whatever. So, secondary to other diseases. But the only thing we know how to modify is the pressure in the eye. So when we treat glaucoma, the only thing that we can really try to, treat to manage is the intraocular pressure. So that's why we'll do laser is now becoming the standard care for glaucoma surgery, or drops or surgery. So those are the 3 things you can do.
Okay.
Certainly the one modifiable risk factor for everything in my mind is smoking. So if you're a smoker, you're at increased risk for cataracts for sure. I'll see a smoker's cataract. You should avoid smoking for glaucoma. You got to stop smoking because, as I said, light comes in, passes through everything, hits the retina. The retina is composed of 9+ layers. And those layers regenerate. And what macular degeneration is, the 9 layers are regenerating and they're leaving stuff behind. They're leaving these particles behind that the retina is not able to process, not able to clean up. They're not able to, sweep the floor after a big event. So that debris stays behind. And then you can get different types of macular degeneration, dry and wet. But basically, dry macular degeneration is when you have something called drusen, think about calcium, like little yellow particles, really. You can think about it in the retina.
Okay.
But then as those 9 layers, the 9 layers have some blood vessels in some of the deeper layers. And if there's enough disruption, those blood vessels become weak and they can leak. Or you can get new blood vessels form is what happens. So you have new blood vessels form. Then you can go from something called dry macular degeneration to something called wet macular degeneration. And at least for the last 15, 20 years, the wet macular degeneration we would treat with medicine. Now, in the last few years, there are some types of dry macular degeneration with something called geographic atrophy, where you can also get medicine delivered to the eye to help manage, your macular degeneration going forward. But for dry, I would definitely tell you, talk to your ophthalmologist, talk to your retina specialist, talk to your primary care doctors, because there are vitamin supplements that, put a plug in for the National Eye Institute. The National Eye Institute is this amazing organization which is part of the National Institutes of Health. But the National Eye Institute has given us so many great breakthroughs and discoveries that have helped everyone to sort of lead healthier lives. So, and also I should mention green leafy vegetables and antioxidants, fish with omega-3s and nuts, that sort of thing. But my point is that you have dry macular degeneration, wet macular degeneration. And for dry, you want to do, healthy diet, sunglasses, green leafy vegetables, salmon, omega-3s, and AREDS2 supplements. Both of them you should see a retina specialist at some point, but the wet ones generally, you may be getting injections in the eye to help treat those diseases.
Okay. So you talked about risk factors, smoking being one of them when we're talking about glaucoma, cataracts, and then AMD, age-related macular degeneration. Any other risk factors? What about alcohol or, I'm assuming bad diet, because we were talking about good diet. Is that in line with what you tend to recommend, or what else do you see?
Excessive alcohol use, I think, is the risk factor for cataracts. That's all I'd say there. If you're taking excessive alcohol, you may most likely have other risk factors also. So
okay, but smoking is the biggest risk factor for this thing.
Yes. Smoking is not the biggest, but smoking is a significant risk factor certainly for cataracts, certainly for macular degeneration, and also for glaucoma.
Okay. Any other big risk factors that we should know about? I
think that there can be the innocent things. I think that, you're on steroids, you don't even know why, and that can be a risk factor for glaucoma and for cataracts. Okay. So I think that, that can be a risk factor for both. So I think that you generally want to avoid, prolonged UV exposure for cataracts and also for macular degenerations. So you don't want to be sun gazing. You want to have, there's something like UV 400 or 100% UVA, UVB protection in your sunglasses.
Really? Okay.
You want to protect your eyes from bright sunlight.
Do you find that light-eyed people are more susceptible to glaucoma, cataracts, macular degeneration than darker-eyed people?
That's a great question. So I think that lighter-eyed folks probably are more susceptible to macular degeneration. I have to get the data on that, quite honestly. I probably wouldn't quote me on that one. But
that's okay. I just wonder, my daughter both my kids have blue eyes. I have darker kind of hazel eyes. And I think they're more sensitive to light because of having lighter eyes. And so I've been told. And so I just wondered if that makes them and other people more susceptible to eye issues as they age.
Yeah. I think that lighter-eyed conceptually would make sense to me for macular degeneration. Okay. For cataracts, it's interesting because I think that, lighter-eyed patients generally, I find they dilate more. So you're probably getting more light into the eye versus brown eyes. Sometimes they don't dilate as well. That might be a little protective in that sense. But I can't be definitive on iris color in that sense.
Okay, that's okay. Yeah. Just made me think of that as you're talking about it.
The Steadfast Care Planning Podcast is sponsored by the Certification for Long-Term Care, CLTC, an in-depth training program that gives financial advisors the education and tools they need to discuss extended care planning with their clients. Look for the CLTC designation when choosing an advisor. If you're looking to become a CLTC, enroll in their masterclass and enter Kelly in the coupon code field for $200 off.
Let's transition to fall prevention. I know that as older adults age, falls are quite common and really one of the biggest things that tend to lead to needing assistance or other issues, hip, legs. knees, that sort of thing. And so we really want to prevent falls as much as possible for good health. So how can cataract surgery help with this?
As you mentioned, falls are a significant public health problem among older people worldwide. They represent the second cause of death by non-intentional injuries. And I found in one study that showed there was like 646,000 deaths by falls occurring annually. So when I see a patient who is hesitant on cataract surgery, but they use a wheelchair, they use a cane, they're having trouble walking, I will say, hey, you might want to think about cataract surgery because it should help to decrease your risk of falling. And I did find one study in 2021 in the Journal of Ophthalmology that found evidence that first eye cataract surgery can reduce the risk of falls in older Americans, but second eye cataract surgery may not have additional significant impact. But the risk of falling, includes, older age, visual impairment, history of falling, whether or not they have cataracts. And then also you get into this thing called, gait and balance, how well their gait is. But falling risk is a big deal, because I remember an old data point when I was in medical school when the attending said to me, hey, once the patient has the hip fracture, the risk of death in the next 2 years goes up like exponentially. It's really like, hip fractures, this is going back 25 years, but one of the biggest risks of falling is actually in your home. So there are modifiable risks that occupational health folks can sort of, help you with like pearls and other things for transferring in your own home, whether it's on the first floor and the second floor. Yeah. But certainly it makes intuitive sense to us, right? That if you have cataracts, and also there are gradations of cataracts, right? So what I find also fascinating is as a patient gets cataracts, their mood changes. Their risk of depression changes. Monet, if you trace his paintings over time, they change in color because of his cataracts.
Oh, no kidding.
And actually totally off subject, but Renoir had bad rheumatoid arthritis. Renoir used to have a pen and he would paint like this.
No way.
And then he put the paintbrush in his mouth, and then he'd have to he'd have to go touch it like that and put it back in his mouth because he had terrible rheumatoid arthritis. That's off subject with cataracts, but you can sort of go with it's interesting to follow artists over time. Certainly in terms of long-term care, one of the biggest risk factors I find Alzheimer's. One of the greatest opportunities we have as ophthalmologists to help patients lead healthier lives is to consider patients who have early Alzheimer's, middle Alzheimer's. They can be depressed, or families may say, we don't want to do surgery because they already have Alzheimer's. But if they can't see their food, if they can't watch the TV, if they can't do what they're enjoying doing, that can lead to increased signs of depression. I have anecdotally had great response with cataract surgery where patients are able to lead healthier lives. And I think that's been the great joy of being an ophthalmologist.
Oh, I believe that. Yeah. If you're not seeing life, if you're not being able to experience what you typically have been able to experience, right, in the decade before now, you're probably not going to be as happy and content. So we want to improve that as much as possible, not just physically, but for the mental health as well. So thanks for sharing that. Talk to us about programs. What kind of programs are available for older adults through Eye Care America? What are eligible patients able to receive, and how can people find out more information about that?
If patients go to aao.org, /Eye Care America, they can just type in Eye Care America and Google, they'll get there. Eye Care America is sort of our white hat program through the American Academy of Ophthalmology. I lobby on Capitol Hill every year for patients and for the profession for the last 20 plus years. We always give the offices, a print ready flyer for Eye Care America. But there are patients who, if you don't have an ophthalmologist, if you don't have, nobody in your community, you can call Eye Care America and they can set you up with an ophthalmologist. Also, if you have Medicare and you have Eye Care America, you can call Eye Care America. And if you're approved through the program, et cetera, there can be a decrease in cost for the first year when you see an ophthalmologist. I would have patients contact Eye Care America for more information about that. But, sort of some of those copays and deductibles can be waived through a program that Eye Care America has approved with the government, with HHS. So that may change in months or years ahead. But the ophthalmologist that you're seeing, it's all volunteer. We're volunteers. So we will agree to waive the deductibles copays for a year. So if, for example, you saw somebody on January 1st and you were signed up through Eye Care America, you can't do retroactive. You call Eye Care America, you do their intake, and they set you up with an ophthalmologist, and then the ophthalmologist is informed that you're an Eye Care America patient. You come there, they'll still bill Medicare, but it may help with your deductible. It can be significant for the first year anyway, not permanent. But
absolutely. I know that medical expenses are a big concern for many older adults. And so how do we minimize that, but still be able to get the quality of care that we need? So that's a great program. So if you know someone that needs some, eye care, check out Eye Care America to see if that might be applicable to you or someone that you know. And then Dr. Goel, any final advice on what people can do or how they can plan for care to live well?
The American Academy of Ophthalmology has hundreds of articles on something called iSmart. If they just type in iSmart, it's patient friendly. They have videos. The content is vetted by committees of ophthalmologists or our staff that writes them with ophthalmology colleagues. Mm-hmm. So, if you have, dry eye, glaucoma, macular degeneration, if you want sort of the early patient-friendly information on those diseases, there are hundreds of topics. That's where I go to. Sometimes if I want to point a patient to, I'll go to that page, I'll print out a page, I'll give it to the patient, or, I'll discuss it. That's a great starting point.
And say that website one more time.
If you just go to aao.org, which is the American Academy of Ophthalmology.
Okay.
aao.org.
Okay.
And then you do just make sure it's iSmart.
Yeah.
Yes. If you go to aao.org/iSmart, EYESMART, aao.org/iSmart, we have an eye health A to Z. So you can sort of search for topics. A little pearl on Google. If you just type in cataracts space aao.org, and it'll search the Academy site. Or any site, really, depending on what you're looking for. That's a little Google search term, Pearl. You just go to the Google and just type in your term and type in aao.org. It'll search that site preferentially.
Great. Well, thank you for that golden nugget.
Thanks.
Well, Dr. Goel, anything else before we leave? What about if people want to contact you or to learn more information about you?
So I have my practice website you can find online, or you just type in protectingsight.com.
Okay.
Or just my first name, last name, md.com. You'll get to my web pages. And I own the site learnaboutcataracts.com, which points to my Protecting Sight page. So I try to make it easy. Just say, learnaboutcataracts.com, and that points to Protecting Sight. So you can learn about cataracts there.
Wonderful. Well, thank you so much for your time and your expertise today. I think people probably learned a lot and hopefully are able to take care of themselves, offer some advice to their loved ones on how they can best protect their eye health as they age. So thank you so much and have a wonderful day.
Thank you for your time. Thank you.